brings me to the introduction of our second speaker, Dr. Michael VanElzakker. He's a PhD neuroscientist, and he also works at Harvard Medical School in Boston, but also at Tufts University. He has a great interest in ME/CFS, and his current research involves performing brain scans on ME/CFS patients and controls. He's very inspiring, and he gets many recognitions of many patients, and he has a lot of experience in multidisciplinary research, and I think this is also a very nice message of this speaker. So please, can you turn on the video of Michael VanElzakker, and he will be attending for answering questions.
Hi everyone, I'm Michael VanElzakker, and I'm a neuroscientist at Massachusetts General Hospital and Harvard Medical School. Really appreciate this opportunity to talk with you about building a collaborative research pipeline in the Netherlands. It looks like I am from the Netherlands with my last name. My paternal grandparents arrived from Rotterdam in the early 1900s. However, I am a typical American in that I have never been to the Netherlands and I don't speak the language, although I definitely would like to go if I ever get the chance. So the goal of this talk, I think, I'm going to go a little bit fast, and the idea is that it'll be a resource that you can later revisit and hit pause on parts where I'm sort of like moving past things, but I wanted to get everything up on the screen. So, myalgic encephalomyelitis, the diagnosis came when researchers noticed that there were outbreaks of infectious illness that led to long-term consequences. Of course, this is in the early and mid 1900s, so there wasn't very good technology to actually measure cerebral spinal fluid and investigate what kind of virus was causing it, and that sort of thing. So it really wasn't known. It was given this term to sort of focus on the symptoms. And then later in the mid 1980s, there was another infectious outbreak, possibly with some environmental issues as well, where again, long-term consequences of this, and the term chronic fatigue syndrome was then coined. This has led to some problems that need to be solved, where there's now a syndrome diagnosis. Even with the more strict ME term, it's still a syndrome diagnosis based on symptoms. In my opinion, that's likely to include diverse causes. So we know, for example, even that some patients with COVID-19 are ending up with symptoms that would qualify for an ME diagnosis according to the symptom-based diagnostic criteria. And so a lot of these patients have not been deeply characterized, and figuring out what is going on in each individual patient ought to be the goal of a really world-class national healthcare and research system. What's happening with each individual patient, which is, in my opinion, unlikely to be the exact same thing. The initiating infection in general has not been well studied. We know, for example, that about 10% of severe Epstein-Barr mononucleosis ends up with an ME diagnosis, never fully recovers. Now, we know that that's a persistent infection. We know that. Herpes viruses stay in the body for life. I personally think that almost surely matters, although unfortunately the research has been overly focused on very simple blood tests, along with an assumption of sterility, an inappropriate assumption of sterility. But this really leads to opportunities where the Netherlands have some really actually amazing researchers doing the kind of work that could really help to crack open each individual patient's case and try to understand what's happening in them. And I'll talk about that in a little bit. So some of the goals of a nationwide pipeline would be a deep characterization of each patient in order to establish a baseline where if the patient gets better or worse, it can be compared. If there's clinical trials, it can be compared to this baseline. That'll advance research for the whole world, really. It could really turn the Netherlands into a world leader in this field very rapidly. Of course, ruling out alternate diagnoses for each individual patient is part of the goal. And I recommend that people visit here to see the primers that explain the disease a little bit, give some background. And also there is a Dutch translation of the International Consensus Criteria available here that I recommend. When I do a study, I certainly collect a lot of demographic information. That includes the standard things like birth, sex at birth, gender, height, weight, etc. I use the International Consensus Criteria. That is centered on the idea that patients get worse after exertion. That seems to be sort of a core symptom in the International Consensus Criteria definition for patients. And that's what they describe is, they sort of are really wiped out by exertion, sometimes manifesting with a little bit of delay, like 24, even 72 hours in some cases of delay since exertion. PEM plus infectious onset has been a criteria, including some of the experts from the mid-1900s, like Melvin Ramsey, who I think really has a lot of important information if you want to read his books. So time since illness onset is an important story. We think there's an immune exhaustion that occurs, and so it's inappropriate to bin together new cases and people that have been sick for many, many years. There's reasonably good evidence that there's T-cell exhaustion and things like that. The nature of onset, again, it's going to be infectious for most patients. In some cases, it will be a medical procedure that perhaps allowed microorganisms to move into the blood from the mouth during a dental procedure or something like that. In some cases, it'll be a head or neck injury that onsets. That's important to record. Make sure you match your control groups appropriately by BMI and activity level. And patient symptoms can fluctuate, and so make sure to measure it in every study. Some specific health-related information for studies: infectious history, including childhood infections, history of antibiotic and immunosuppression use. There does seem to be a phenotype that is a vulnerability to this diagnosis, a hypermobile phenotype, so Baton scale score is an important bit of information for each patient. There's perhaps a vulnerability with spina bifida occulta, which is surprisingly common, 10 to 15% of humans. And you can see this sometimes with a sacral dimple. Vascular stenosis is causing the syndrome diagnosis in some patients. A lot of times you're not going to see the effects of what's driving the symptoms unless there's a postural change. That's really important for some patients. And again, the differential diagnoses, there's classic ones like multiple sclerosis, Parkinson's, myasthenia gravis, but then there's some structural, differential diagnoses that ought to be examined and ruled out in individual patients, like Eagle syndrome, spinal or vascular stenosis, Chiari, tethered cord at the lumbar end of the spinal cord, cranial cervical instability. And this pipeline is a chance, I think that research groups in the Netherlands ought to publish if they find individuals who have been essentially misdiagnosed or perhaps improperly psychologized. That ought to be something that makes it into the literature so we can all learn from it. And this is a good resource for some of the questionnaires and things like that, things to measure. So I'm a neuroimager. I would love it if everyone in the Netherlands had this, every ME patient in the Netherlands had this group of neuroimaging. So at least a 3 Tesla field strength. Getting head and upper cervical is important. Full spine would be even better if that's possible. A T2, T1 and T2 weighted images, and the T2 flare or T2 star. If they all could get this, that would be a really great thing to add to the literature. So this is a recent paper from collaborators of mine in Sweden, the Brage Institute, that's adjacent to the Karolinska Institute, sort of pointing to the what seems to be the case, that part of what's driving the symptoms, or is at least associated with patients, is intracranial hypertension. There seems to be some structural vulnerability. So this paper includes a whole bunch of measurements that I would love it if all the patients in the Netherlands underwent these measurements after receiving these scans. And then you could contact either myself or this research group, and we could make it a much larger study to try and understand the level to which this reflects a vulnerability factor or an actual disease process. Some other neuroimaging suggestions. Generally speaking, I've been focused on vagus nerve and brainstem. I've got some papers on that you may be interested in. The autonomic nervous system certainly seems to be affected, so that's part of the reason why brainstem is important to image. The neuroimagers out there know that brainstem is not easy to measure. You have to do a lot of sort of specific ways to reduce the physiological noise, and so getting brainstem imaging experts would be really nice. Cerebral spinal fluid flow and intracranial pressure seem to be part of the story, so imaging that. Again, upright versus supine is going to be part of the story of symptoms for some people. So an upright flexion and extension, you could use a CT or X-ray if you don't have an upright MRI. The vasculature also seems to be part of the story, of course, related to cerebral spinal fluid flow. So a time of flight or MR angiography would be important, if, even better, a sort of a proper angiography. And then, of course, there's a lot of other things that could be done with neuroimaging. So symptom provocation, again, the sort of core symptom is the exacerbation of symptoms upon exertion, and that sort of points to the idea that symptom provocation might be an important model. You have to decide if it's worth it, because patients can really end up feeling sick for a long time. It can be really substantial. So, I think it's a really important ethical decision of whether it's worth it, and are you getting the most, if you decide to do a symptom provocation technique, are you getting the most out of it? So classically, Stacy Stevens from the Workwell Foundation, Betsy Keller at the University of Ithaca, sort of found that VO2 max especially just drops way off with a 2-day exercise test. So those are papers that are worth that are worth reading and addressing. Tilt table test is provocative for many patients. The straight leg test, Peter Rowe has been focusing on these sort of issues for a long time. The idea that in some patients their symptoms will exacerbate from stretching nerves, again pointing to some structural vulnerabilities. I've talked about upright versus supine. And getting any sort of physio measures during that comparison of upright versus supine is really valuable. We have done some work with measuring the middle cerebral artery using Doppler and that sort of thing. And again, if you provoke the symptoms, if you make patients feel worse, sometimes that will include flu-like symptoms. And so that would be a good opportunity, for example, to, let's say, aspirate lymph nodes before and after they feel these flu-like symptoms. What's happening there? There's a lot of things that you can do with these provocations to try and understand what's happening. In general, just moving beyond simple blood tests, which, we know you cannot use blood tests to detect everything that's happening in the human body. You cannot use it to detect every organism that's in the human body. It just doesn't work like that. That's not how the physiology works. So moving beyond that is a really important priority for the field. There are some really amazing researchers in the Netherlands using next generation sequencing that could be doing samples from, either other tissues or from throat, lymph node, nasal swabs, etc. Carefully collecting the samples. You can use techniques like T-cell sequencing to try and understand what the immune system is targeting. We know, for example, that so-called autoantibodies are formed in response to pathogens, and there are overlapping proteins that cause these antibodies to cross-react with self. That's an important thing, and it would be an important thing for people who study to sort of try and understand. Again, not every autoantibody is going to be the same in every individual patient, but we do see anti-ganglionic, anti-acetylcholinergic, anti-serotonin in some patients. If you collect cerebral spinal fluid, that can be really valuable. You don't necessarily want a centrifuge if you want to look at the cells. Although, again, if there's a hypermobile phenotype, you have to be really careful with lumbar puncture, because you can end up with a cerebral spinal fluid leak. The activational state of cells is an important thing to look at beyond just presence or absence of a cell type. what are they actually doing. So using transcriptome-based techniques is really valuable. Anytime you can get tissue from patients, that's valuable. So Anne-Louise Oaklander has shown that about 30 to 40% of patients with this diagnosis show small fiber neuropathy. That would be an important thing to measure in these patients. And then once the small fiber neuropathy is characterized, to further characterize those tissue samples. And for what it's worth, the fibromyalgia diagnosis has an even higher rate of small fiber neuropathy. That's a diagnosis that heavily overlaps with the ME/CFS diagnosis. And a world-class national research pipeline ought to have pathologists that are prepared for inevitable autopsies. Matthew Anderson at Harvard Med, my colleague, has some really great ideas about that I can sort of explain to people. General suggestions: use groups that are already doing relevant work. If you can have a system like the United States has for autism, in which each patient has a de-identified number, so that if I, for example, do a brain imaging scan and then someone miles and miles away does a cerebral spinal fluid scan, we have both uploaded our data to a common repository, and we can use that de-identified number to compare across different studies what one patient's measurements are. So that could be a really important thing to note. In general, I think rare variants may be an important thing to sort of keep in mind. Our studies use take-home sleep devices where we give a sleep device to a patient 2 nights before they show up to a research scan. And that's a valuable thing, to let people sleep at home, because sleep is disrupted in these patients, and trying to understand how it relates to symptoms or causes is important. So my apologies to Dr. Vanderhoek. I have not contacted her and asked for her permission, but she's just a really cool researcher in the Netherlands who does really good pathogen identification. So trying to understand what's happening in samples from patients is a really top priority, in my opinion. Not just blood again, but tissue and other fluids and things like that. So this is what I mean by bringing groups that are already doing good work into the pipeline. So here's another group that's already doing good work. Jasper Verbry does really cool work to try and just understand how to measure the middle cerebral artery. So, I've got data showing that brain perfusion is affected by even very minor autonomic challenges. It's not the same in every single patient, again, but being able to measure what's happening in terms of blood flow in the brain is really valuable. And there's just some, conferences that focus on infection and how organisms can sort of form in patients. Just some things to keep in mind. Some resources. So I'm going to show videos that you can watch later. So this is Dr. Kenneth Liu, who focuses on vasculature in the brain. And it's really worth considering that not just the arteries, but the vasculature can become disrupted, and it does seem to be overrepresented in patients with this diagnosis. So Peter Rowe is one of my favorite MDs that work on this condition. He's really focused on the autonomic system, especially in that sort of hypermobile phenotype. It's really worth getting some physiologists to watch some of his stuff and think about his perspective. Dr. Amy Prowl is another close colleague who focuses on a lot of these patients will have multiple infections that sort of cause them to gradually get worse and worse. And her focus in research is how these organisms interact with one another and perhaps driving symptoms. So this is another one that's worth watching. This is a physical therapist that focuses on how to work with patients with hypermobile phenotype in a way that won't make them worse. So this again is a place where you can hit pause later. In my opinion, there will never be one medicine that just works for everyone. I hope I'm wrong. I don't think I will be. And what it's going to take is thoughtful, personalized investigation. And there are a lot of different things that can work for some patients. It's not true that there's nothing that works. But we have to do as an individualized sort of investigational approach And another favorite doctor, Dr. David Kaufman, sort of takes that approach, and I think it's really valuable. And just as a one last note, there is this sort of issue that's happening in the patient community related to cranial cervical instability. These are serious surgeries. I think in most cases, physical therapy, that's different than exercise. Physical therapy can possibly help some of the patients that show this very severe CCI phenotype that has been given the diagnostic label of ME/CFS. But any surgeon in the Netherlands who's doing this work should be communicating with other surgeons that have been doing the work for years, because we really need to connect and make sure that we're sharing best practices. So thank you for listening.
Thank you, Michael, for this wonderful talk, convincing talk that we really should deeply characterize ME/CFS patients. I'm looking at Sabine. Are there any questions in the chat?
Well,
for
there's
Michael?
some. Yes, thank you. There's some discussion online in the chat, but not too many questions. I have one question here by Lou Corsius, or should I say Lou Corsius? He asks, your recommendation is to deeply and individually characterize patients. Are there several subgroups amongst ME/CFS patients? And now my chat whopped. Were you able to identify subgroups, and what are shared factors within these subgroups?
Yeah, so thanks everyone for having me. First of all, I appreciate the opportunity, and this is a really, really great opportunity for the Netherlands. I think you could be a really world leader. I think you can talk about subgroups in different ways. So for me, the onset is probably really important. So for example, if there are particular individuals that started with a mononucleosis, I would think of that as a subgroup that's important. I don't think that it's going to be the same thing for everybody, so it kind of depends on your perspective how you decide to group according to subgroups. You may consider one subgroup that has particularly bad intracranial hypertension, for example. I think that you're going to end up splitting it down into many subgroups. I know that's not a really satisfactory answer, but it kind of depends on your perspective. If you want to start from the onset, or if you want to start with current symptoms or current presentation, I think it's just important to sort of not overly bin everyone together, because you may miss some signal from an individual because it doesn't come out in an average.
Thank you, Michael, for this answer. Sabine, do we have more questions in the chat?
Not so far. There was one person in the chat, Karen. She had a question for clarification, I think. She said you spoke about postural changes and the effects on ME/CFS. She was wondering what kinds of postural changes you were referring to.
So it's kind of amazing that any of us can go from lying down to standing up without just passing out. There's a lot of autonomic changes that need to happen from very simple postural changes. That seems to be disrupted in many patients. So there's a particular diagnosis called postural tachycardia POTS that is in a large percentage of patients. It's not the exact same thing. But for some patients, their symptoms really get worse going from lying down to standing up or sitting up. And that's what I mean by postural changes. We found, for example, that there are some autonomic dysfunctions that we don't see if a patient is lying on their back, but that we do if they're sitting up or standing up. So in measurements, in my opinion, that's an important thing to examine when you're looking at autonomic function. And even just a simple middle cerebral artery Doppler from the group that I mentioned in the talk, I think would be a really interesting and important thing to measure for each patient.
Thank you, Michael. Sabine, do we have other questions?
Yes, we do, if you still have the time.
Yes, we have.
I have here Professor Wilco Pearl. He asked, dear colleague Elsocker, the last slide shows CCI as an entity. Real instability is difficult to define in ME as well as brain problems. Do you agree that surgery should be done in a study surrounding?
Yes, I mean the surgical thing. There's a prominent patient that had apparent cervical cranial instability and had a surgery that remitted symptoms in her case, and that has caused a lot of people to be really focused on this idea that they may get better with the surgery. It's a really major surgery, and I think we should be really cautious and careful about that. It is very difficult to sort of diagnose. I mean, there are some measurements and scans. There are ongoing studies happening right now on this topic. I don't think that CCI and ME are the same thing, certainly not in everyone. Given that ME is a syndrome diagnosis, there's going to be a lot of different potential causes, and there is apparently, if you want to talk about subgroups, there is a subgroup in which cervical cranial instability is driving some of the prime symptoms. But I absolutely agree that it's a serious surgery, and for the vast majority of people, that's probably not the option that they should be looking for.
Thank you, Michael. I have a praying question. As you explained, what information you should collect for patients, and I'm an immunopharmacologist, so I'm a bit biased. But you explained about the infection history, which might be very relevant in the current pandemic, and the use of antibiotics and immunosuppressive drugs. But why didn't you mention vaccinations? And especially now with the development of the new COVID vaccines, this might be very relevant. Can you elaborate on this a bit more?
Yes, you're right. I mean, there are some people that have had bad response to vaccinations. I mean, in the United States, unfortunately, the culture is that if someone sees me just saying that sentence that I just said, I could get in a lot of trouble for just pointing out that sort of empirical fact. Unfortunately, it is an issue for some small number of people. Again, the vast majority of vaccinations are, people are just fine, but for some people, there are autonomic consequences, and understanding why that is, I think, is important. So yes, I'm probably going to get in trouble for saying that.
Oh, I'm so sorry. I do not hope so. And I have another question. If Sabine doesn't have any other questions from the audience.
Actually,
Okay, then they go first.
For instance, Kitty is asking online, how can you study the severely ill? For example, she's bedbound. How would she be able to participate, or other severely affected patients?
It's a really good question, and it's just a difficult problem. It just is a difficult problem. To do the primary studies that I do, patients need to be able to come into my center and get into a brain scan. Especially for the PET study, we do, an arterial line that's invasive and difficult. So I understand that the very severely ill want to participate, and it may be the case that they have to participate in sort of less invasive ways. Donating a saliva sample and things like that can be very valuable and useful. I personally hope that even the very severe will try to get a brain scan, but it's just a difficult problem, and you run into the issue of, if you study the less severe, there may be different mechanisms happening than in the very severe, and it's just a difficult problem. To the extent that we can, we should try to do home visits if we can, so that scientists can go to people's homes and collect, saliva, blood, whatever they can. But it's just a difficult problem, and I feel empathy for those very severe patients that want, first of all, information about themselves and want to help with research.
Thank you very much for answering all these questions, Michael, and also for your presentation, but we have to continue with the program.